All right. Hello. Welcome back, clinical problem solvers, to another Rafael Medina subspecialty VMR. My name is Leia. I'm one of the Academy team members, and I'm really excited that we have a rheumatology subspecialty VMR today. And our guests are Eli Miloslavsky and Anna Valle. And I will just briefly introduce them in the beginning before I pass the mic on to the two of them. So our case discussant today is Eli Miloslavsky, a rheumatologist and associate professor of medicine at the Massachusetts General Hospital and Harvard Medical School. Eli's career has been focused on medical education across all stages of training, and he serves as a curriculum phase director at Harvard Medical School, firm chief in the MGH Internal Medicine Residency Program, and associate program director at MGH Rheumatology Fellowship, and also leads the MGH Clinician Educator track for Department of Medicine Subspecialty Fellows. And our case presenter today is Anna Valle, MDA, and MHS, and is a rheumatology fellow at Brigham and Women's Hospital. And she attended Johns Hopkins University and the Johns Hopkins Bloomberg School of Public Health, where she studied public health, and during her undergraduate and graduate years. Afterwards, then she worked as a research coordinator, which introduced her to the field of rheumatology and instilled a passion for clinical research. And then she obtained her medical degree at Zucker School of Medicine at Hofstra Northwell and completed residency at Montefiore Medical Center in the Bronx, New York, where she was awarded the Intern of the Year and Ambulatory Chief. And now she's pursuing a clinical research career and dedicates time to address health inequities within rheumatology and further understanding of idiopathic inflammatory myopathies. And those of you who've been here a few months before will know the two of them. They have been guests here already. And to kind of start us off, I wanted to ask the two of you, what was actually the reason that you chose to go into rheumatology, and what do you really enjoy about it? And maybe Anna, if you want to go first.
Certainly. I just want to say thank you for having us again. I'm very excited to be here. Became interested in rheumatology pretty early in my medical career because I could see how women of all ages were impacted by these rheumatic conditions. We did not know as much about these conditions like we did about other subspecialties in internal medicine. I saw women being affected from all ages, all walks of life. They remind me of my own friends and family, and I wanted to be able to help them achieve their own goals and passions in their lives without having to kind of have their lives shortened or be limited by rheumatic conditions. And so what I love about my about rheumatology is that we get to have really special relationships with our patients through time. These are usually really close longitudinal relationships, and we know each other really well because we're having really important risk-benefit discussions about medications, about what to look for in the future, and how to prognosticate their disease. And there, as I mentioned, there's always still a little bit more space for clinical research too. So there's always plenty of times to have, be inspired by a patient and their specific clinical condition, and then be able to apply that in clinical research.
Yeah, and so I agree with what Anna pointed out about our specialty. I came to it though in a totally different way because unlike Anna, I had no idea that I wanted to be a rheumatologist until midway through residency. And I think the way I started to think about it was that I really loved internal medicine, but I wanted to be a specialist in some aspect. But I felt like a lot of the specialties were so single organ focused that I really didn't want to lose like the breadth of what internal medicine had and the kind of the need to really know and think about all of the organ systems. And that's kind of how I came to rheumatology from that and kind of this love for diagnostic puzzles, which are so frequent in our specialties. And then that ability to like walk with a patient throughout their entire journey and build those relationships that Anna talked about. And, since becoming a rheumatologist, I learned many other perks, but I'll just highlight one. Our medicines are much better than they were, and you could make almost everyone better, which is just like an amazing feeling to have when someone walks into your office.
That's amazing, and I can only echo what is here. Of course, a bit biased as myself going into the field of rheumatology, but I feel like it's such a diverse field, and also the community of people that I've met so far were so enriching. It's a really, really cool field, and excited to learn more rheumatology today. So, Anna, if you're ready, feel free to start the case.
Certainly. So I will go ahead and start with the chief complaint. So Mr. Zeppelin is a 48-year-old man who presents due to 1 month of right large toe pain. Okay, and starting with the history of present illness, 1 month ago, he woke up with toe pain in his right big toe, as I mentioned. The night before, he had been playing a gig at a private party. So, as a bass player, he was on his feet for multiple hours. And when he finished playing, in order to reach his audience, he hopped the fence in order to join the party. And once he got to the other side, he was having multiple sweets that he wouldn't normally indulge in his normal afternoon, and but those were the only other abnormalities that he noticed was different on the night prior to the start of his toe pain. Now he describes the toe pain as an 8 out of 10. It feels like a strong stinging sensation. It does not radiate. It gets significantly worse when he bears weight or tries to move his toe. He has noticed his toe is hot and swollen to the touch, and also has been quite red. He has tried some ibuprofen, about 400 milligrams, about 2 times per day, which did help his symptoms, but it seemed like these symptoms would always return, and the swelling and redness never fully went away. This led for him to present to urgent care, where he was told that he has gout. They gave him colchicine, which took the edge off of his symptoms, but once again, the pain never really resolved. So he went back to the urgent care where he was given what we refer to as a Medrol dose pack, and he was handed a referral to rheumatology, which is when he saw me.
Okay, thank you so much for the first aliquot, Anna. So, Eli, we had a lot of information now. What are your first thoughts that are going through your head, and how are you structuring this information?
Well, I think my first thought, probably like everybody else's here, is that, wow, this sounds a lot like gout, a toe that's like painful and perhaps inflamed. But, I think that level one thinking, or system one thinking, I should say, is really important to kind of get a sense of what it could be. But it's always important to kind of take a step back and just think about this as, a monoarthritis, or pain in a single joint, and think about the buckets here. So this is something that could be mechanical, or it could be inflammatory, and that's kind of the first branch point. um, and that's probably the more important branch point than even thinking about, well, which inflammatory condition could it be? But it's important to recognize that, gout is an inflammatory arthritis, just like many other inflammatory arthritides, including rheumatoid arthritis and spondyloarthropathies, et cetera. And while this doesn't fit that right now, it's kind of important to consider this in the kind of the bigger bucket of inflammatory arthritis. Now, thinking specifically about gout, we often spend our time thinking, well, here's my working diagnosis, what doesn't fit? And I think we could apply that lens. So gout, especially the first episode, often self-resolves. So 1 month of symptoms is not unheard of, but it's like a little long for what I would expect is a typical gout flare. And it has not responded to treatment that gout might typically respond to, although certainly not all gout will respond to colchicine, or a short course of prednisone. So I think those little tidbits just open this up to other possibilities.
Okay. And so when I asked him additional questions, he mentioned he has never had an episode like this in the past. This is his first episode. He does not believe he had drank any alcohol before it started, doesn't recall any seafood either, no meats such as a steak. And when I asked him about other joint involvement, he said his toe is by far the worst joint, the most severe joint, but he has noticed that over the last 2 months, he has woken up with the sensation that his hands are stiff. And first thing in the morning, it's difficult for him to make a fist. It feels good to take a hot shower, and his hands seem to improve. This doesn't seem to last all day, but it seems to come back day after day. And let's see, and he did not mention that any of this joint pain wakes him up overnight. And he said that in the morning when the hand pain is at the hand stiffness, I should say, is at its worst, it does last for about 2 to 3 hours.
Okay. So we heard now some additional information. You talked in the beginning about differentiating inflammatory from degenerative pain in a patient. How does this information help or add additional information? Why is it important to ask about the duration of the stiffness?
Yeah, that's kind of a key point. And I think if there was one thing that we would love for folks listening to take away is how do you differentiate inflammatory from non-inflammatory joint pain, because the differentials are so different. And I think there's actually a mnemonic that I like to think of when thinking about inflammatory joint pain, which is I am not great at mnemonics, and this is just something I made up myself, so it may not be the best, but it's LIDS, L-I-D-S. And this is just to kind of help me remember what are the key features that I want to ask about when differentiating inflammatory versus non-inflammatory joint pain. So L is location. And in this case, that's super important, right? In the beginning, it was a monoarthritis, a single joint that we learned about, which has a high chance of being mechanical, but could be inflammatory. Once multiple joints become involved, the likelihood of an inflammatory process goes up. And this is where specific locations of joints are really important. So I'm very curious about the hand stiffness and where, in particular, what joints are particularly affected. For example, the MCPs and the PIPs, so the metacarpophalangeal joints and the proximal interphalangeal joints, if that's the pattern, then that is a pattern that really suggests an inflammatory process, as opposed to if in the hands, if it was like the PIPs and the DIPs, that might be seen more commonly in osteoarthritis, for example. I is for inflammatory features, and what you mentioned about the morning stiffness, that's kind of a key question we ask, because inflammatory joint pain often presents with pretty prominent morning stiffness. We think of it as longer than 30 to 45 minutes. I think sometimes people ask that question in a way like, is your pain or stiffness better in the morning or at night? And I find that question a little bit challenging because people with inflammatory arthritis have a lot of pain at night. So the way I usually ask that question is, when you wake up in the morning, do you feel stiff? Yes. Does that stiffness get better as you get going? Yes. How long does it take on an average day to feel as good as you're going to feel that day? And hours of morning stiffness is definitely suggestive, although not diagnostic of an inflammatory arthritis. Similarly, presence of swelling would fit into this inflammatory symptoms category. D is for duration. So, acute versus chronic just kind of helps change our differential. And then S is for systemic symptoms, right? So symptoms that people might have outside of the joints that might help us think about, is there more than just an inflammatory arthritis going on? Is there a systemic disease that's affecting other organs or causing other symptoms? So certainly the distribution and the morning stiffness here are definitely points for an inflammatory process.
Mhm. And as I continued my review of systems, he mentioned he's also had pain on the bottom of his right heel and over the posterior aspect of his right ankle towards his Achilles tendon on and off over the past 7 years. He also mentioned that he's had more, like it's acutely worsened plantar fasciitis, in his words, over the last 4 months. He thinks his nail in his left pinky toe has been changing a little bit. He's noticed it looks a little bit odd. And he has a very small rash on his bilateral anterior shins, which, he doesn't quite know what it is. His PCP may have told him it's eczema, and but it responds very well to a steroid cream, so he actually doesn't really think about it too frequently. He denied any fevers, chills, night sweats, unintentional weight loss. He did not have much fatigue. He did not have a recent upper respiratory illness. He did not have dry eyes or dry mouth, nausea, vomiting, acid reflux, diarrhea, hair loss globally or in a specific location, photosensitivity, mucosal ulcerations, Raynaud's. He also denied any history of ocular issues, any times that his digits have looked really swollen like sausages, any history of low back pain, or personal or family history of inflammatory bowel disease.
Now, that is interesting new information. Is there something um, that stands out to you as you hear all of this?
Yeah, well, I think what really stands out is a pretty negative review of systems, and that's really helpful. I think rheumatologists really pride themselves on their history taking, and I think that old saying that um, you get to 90% of the diagnosis just from the history is often really true in rheumatology. So this is a really helpful and comprehensive history. When we think about rheumatic diseases, even though there's many of them, I think for the most part, they can be classified into kind of three categories. The first category is inflammatory arthritis. Second category is connective tissue diseases. These are the ANA positive diseases like lupus, scleroderma, Sjogren's, myositis, and then the vasculitides. And actually, the first case that Anna and I did was a case that really touched on all three of those categories. Which is tricky because the more categories, the broader your workup has to be. But in this case, what we're getting so far is that the symptoms are all centered around essentially joint and what sounds like enthesial, we'll get to that later probably, pain. But there's no suggestion that other organs are involved. So we're squarely in the inflammatory arthritis category. And there's like a set number of conditions that live in that category, even though basically all rheumatic diseases can cause joint pain. When joint pain is really isolated, then we're really are kind of thinking about that category alone as where the most likely diagnosis lives. So what we have so far in the negative review systems is really helpful in narrowing down the list of possibilities.
Yeah, amazing. And we heard that there were changes on the skin and also on the nail of the patient too. Is that something that you just note and then continue, or is this helpful in any way for your differential diagnosis?
Totally helpful, probably, right? We don't know exactly what the skin looked like at this point, but I think as a med student, I kind of really enjoyed dermatology and how you could look at something and just have a diagnosis. And a really fun part of rheumatology is that there are a lot of joint skin conditions, right? And kind of we still are able to do some of that. So this may be an example of that, and we'll see. But maybe it's good to kind of get a list of the conditions that live in the inflammatory arthritis category, which will kind of answer Leah's question of how this might be relevant. So probably the most common condition that causes inflammatory joint pain, as the only presentation, is rheumatoid arthritis. And then the second category is spondyloarthropathies. And there's 4 of them. They're good to think of in terms of like an umbrella category because they do share similar features, although each one's a little bit different. I think folks in the chat are already thinking about psoriatic arthritis, and that's definitely on the list here because that can involve the skin and the entheses, which are the insertion sites of tendon onto bone, like plantar and Achilles entheses. Ankylosing spondylitis goes in this category, reactive arthritis, and IBD-associated arthropathy. And then crystal arthropathies are the other category here. Gout and pseudogout live in that, under that umbrella term. Polymyalgia rheumatica, think about in the inflammatory arthritis bucket. And then the infectious arthritides are good to think of here as well. And that's kind of the universe. It's not dozens of conditions, right? And so we could narrow our differential down just by thinking of, is this an inflammatory arthritis connective tissue disease or a vasculitis? And so when you think about skin, entheses, and joint involvement, and nail involvement, psoriasis and psoriatic arthritis certainly comes to mind as a possibility.
And so before we get to his physical exam, as we continue with past medical history, he has allergic rhinitis, hyperlipidemia, hypertension, eczema is listed on his medical chart, rosacea as well, and a remote history of hepatitis A while he was traveling many years ago. He also broke his foot in 2015, and he takes the steroid creams that I mentioned earlier. He also had the Medrol dose pack that I had mentioned earlier, and he's on a hydrochlorothiazide. He does not take anything for his rosacea since it doesn't bother him and it occurs quite sparingly. His only surgical history is a vasectomy when he was approximately 35 years old. His social history, as I mentioned, he's a bass guitarist. He's married without children. He is a social smoker, he said, which averages out closer to half a pack per week over the last 20 years. He averages 21 drinks of alcohol per week. And that correlates more when he has shows and kind of other social engagements. So it might be closer to around 6 to 7 drinks in 3 nights of the week. Daily cannabis use, no other illicit substances. And no known allergies.
Thank you, Anna. So Eli, we have a bit more of history and health-related behaviors too. How does the past medical history and medication change your differential, and what weight do you put on family history?
Yeah, it's both great questions. So family history is a little bit tricky because it's kind of more important for some conditions than others. So for example, for psoriatic arthritis, a family history probably carries a little bit more weight. And it's helpful to know if there's a strong family history of autoimmunity. But I must be honest, in terms of thinking about what this patient actually has versus their family history, the patient's actual history is so much more important. So it's pretty uncommon unless we're talking about like monogenic genetic disorders or things like or like connective tissue disorders like Ehlers-Danlos, et cetera, that have a really, really strong genetic component. A family history is kind of a small point in the greater scheme of things. In terms of this patient's social history, I definitely know that he drinks a fair amount of alcohol, 21 drinks a week, and it might all come in like uh, more episodic
Concentrated
pattern.
episode.
Um, and definitely we think about that being a risk factor for gout. Uh, and so you have to take that into the broader scheme of things. But already gout was high on the list in the very beginning, and we noted some inconsistencies with that. So I think it's something that I note, but I probably wouldn't let it drive my diagnostic decision making.
So moving
In
on.
in the end, I will just add that even though in medicine we always ask why, right? And we always try to identify the drivers of what we see. So many of our diseases and flares of our diseases, we actually can't identify triggers for. So that's just something that today is the reality of things. And maybe in the future, we'll be able to identify drivers more.
Hmm. So moving on to physical exam, his blood pressure was 116 over 64, pulse 73, temperature 96.6 degrees Fahrenheit. He is 6 feet tall and weighs 200 pounds, so he has a BMI of 27. He generally appeared well. His head, ear, nose, and throat exam was completely normal without exudates, moist mucosal membranes, full ocular movements. He did not have any lymphadenopathy in his neck, and his chest. His respirations were regular, and he was cleared auscultation bilaterally. His cardiovascular exam, he had regular rate and rhythm, normal S1 and S2 without murmurs, rubs, or gallops. His abdominal exam, his abdomen was soft, non-tender, non-distended, and his extremities were warm, 2+ pedal pulses without any edema. And his neuro exam he was a no times 4, and generally non-focal. In terms of his skin, he did have two by 2 centimeter lesions on his anterior left shin that seemed overall consistent with post-inflammatory hyperpigmented changes. I didn't see any specific flakiness or any kind of active erythema there. They seemed to kind of be a little bit older lesions. Um, However, when I looked on the back of his head, I saw a 1 by 1 centimeter lesion on his occiput, which was more erythematous with some mild scaling. And he also had a similar lesion behind his right ear. And when I took a look at his nail on his left pinky toe that he had mentioned, it was a really thickened and yellow nail. It seemed, however, that was the only nail that was affected. The rest of his nails had some lines in it, but did not have any pitting. I did not find any other nodules, any areas with missing hair, such as alopecia, any telangiectasias or pustules over his face. And in terms of his musculoskeletal exam, when I examined his hands, his left third MCP, PIP, and DIP were all tender to palpation, even though there wasn't any erythema, really minimal warmth and very minimal swelling in these joints. When I squeezed his left MCPs together, he endorsed that that was quite painful. His right hand did not have any significant tender in the MCPs, PIPs, or DIPs, and his MCP squeeze on the right hand was negative. When I evaluated his hips, he had really full range of motion. He was able to lean forward and fully and nearly touch his toes without bending his knees. When I asked him to not to keep his legs extended and bend from side to side, he also had really good flexibility on with lateral motion. And when I rolled his legs and did a Faber test, those were also both within normal limits, and did not elicit any pain. When I looked to his knees, ankles, feet, and toes, um, his right first MTP had mild tenderness to palpation, and it was still significantly swollen, although not as erythematous and not as warm. He had a full range of motion, but kind of the extremes of flexion and both extension did cause some discomfort, even though he was generally able to walk on that toe. And his MTP squeeze was positive on that right side, but negative on the left side. And so no tenderness to palpation along any of his MTPs on the left.
Wow, that was a lot of information. Thank you very
Yeah.
much. Um, the Yeah, so first, maybe let's start this off. What are your general thoughts about hearing all of this information? And then in your mnemonic that you shared with us in the beginning, the first letter stood for L, so for location. And now we have more of an objective exam for the patient. How does how would you categorize location for this patient?
Yeah. So it just maybe start out by saying that, the one fun part of rheumatology is that the exam really matters. And that's definitely the case here. And Anna did a phenomenal exam where she kind of thought to look, at the scalp and areas where psoriasis might hide, right? So the exam here was really hypothesis driven, and it's so helpful. So I note kind of, I guess, three things about the exam that are worth commenting on. One is that there was definitely a swollen joint, being the toe. And that's really helpful because inflammatory arthritis almost always has at least one swollen joint. And we have that here, and that further increases the likelihood of an inflammatory process, although certainly trauma and fractures can cause swelling as well. Two is that the locations here, I think most people would classify it as asymmetric, right? Because you have the left third MCP, PIP, and DIP that are tender, and the right toe that is tender, but other areas are non-tender. So there's some asymmetry to the involvement. Asymmetric involvement is not a slam dunk for anything, but certainly the crystalline and the spondyloarthropathies can be asymmetric, whereas rheumatoid arthritis, VMR, are more typically symmetric. So that's maybe a point for inflammatory arthropathy, spondyloarthropathy. The fact that a DIP might be involved is kind of another hint. Psoriatic arthritis as well as gout can involve the DIPs, whereas other conditions very uncommonly do so, like rheumatoid arthritis is pretty uncommon to involve the DIP. And then probably one of the most important things to note is that there were a lot of joints that were tender and not swollen. And I think this kind of highlights a common misconception that all joints have to be swollen in an inflammatory arthritis, and that's just not the case. You do want to have at least one swollen joint, and sometimes that swelling can be really subtle, so you may not be able to pick up on it. And that's why if there is inflammatory joint symptoms by history, and you're not necessarily seeing that on exam, it's still important to be thinking about an inflammatory arthritis as a possibility. So I think the exam here does not absolutely confirm, but supports our kind of hypothesis that this may be an inflammatory arthritis and that you have kind of an asymmetric small joint arthritis here. And there is no involvement of the back or the entices, at least on exam. And those are the other features, other musculoskeletal features of spondyloarthropathies that makes it different than rheumatoid arthritis. So back involvement, DIP involvement, enthesial involvement, and asymmetric arthritis are all things that we often see in the spondyloarthropathies, but not so commonly in rheumatoid arthritis.
There were so many pearls here. I love the discussion so far. Maybe an interesting question would be, what tests would you order for this patient to kind of narrow down your differential further and get closer to what the underlying disease might be?
Yeah, so I think it's great to just start with what tests are at our disposal in general, right? There are labs, there's imaging, and then there is like tissue, right? Those are like the three big the three big categories of tests. So we could start with thinking about labs. It's kind of rare to walk into a rheumatologist and walk out without any labs. So we could start there. You know, we always get basic labs, right? Because it's important for possible future treatment, you know, in terms of like CBC, complete metabolic panel, and there might be hints on those that alert us to kind of other conditions that we may not have thought about from history. And then it's important to kind of think about, well, what labs might be helpful for this, for inflammatory arthritis as a bucket, right? And if you look at those, if you look at the conditions that are in this bucket, you'll see that the only one that really has kind of good serologies is rheumatoid arthritis. So someone mentioned in the chat, rheumatoid factor and an anti-CCP antibody. And we always get that in a case like this, really just to make sure that it's not rheumatoid arthritis, even though that's not necessarily the high on our list here. But because the treatment of rheumatoid arthritis is so different, and because the CCP antibody is really quite specific, whereas the rheumatoid factor much less so, that's appropriate to get in this setting. And actually, psoriatic arthritis criteria require a negative rheumatoid factor, or don't require it, but it's one of the points for it. So for the spondyloarthropathies, there's not a great test. HLA-B27 is something to consider. HLA-B27, though, has better test characteristics for patients with axial disease, those with spinal involvement. This patient doesn't have that. So I think it's reasonable to get, but it very well may be negative, and it may not change how we think about this patient. And then inflammatory markers, ESR and CRP, are really helpful for all three of our categories. So we would get that here. And then the question of an ANA comes up frequently, right? Should I get an ANA in this patient? And I think it's important to just highlight that an anti-nuclear antibody is really only helpful for diagnosing the connective tissue diseases, right? That's our second bucket of diseases. That's lupus, Sjogren's, scleroderma, myositis, and mixed connective tissue disease. And I think sometimes we get an anti-nuclear antibody for a presentation of just joint pain, because sometimes lupus, for example, can present with joint pain as a first manifestation, and you might check an ANA to exclude that. But in this case, I find that it's pretty unlikely that that's the case, because we're talking about a 48-year-old male who is not a common demographic for lupus, and you have an asymmetric inflammatory arthritis, perhaps with psoriasis on the skin. So all three of those things make lupus kind of unlikely, and lupus has a similar joint distribution to rheumatoid arthritis, which doesn't seem to be the case here. So while it's reasonable to get, I would also be perfectly happy not getting it as kind of a first step. But the typical workup for the inflammatory arthritis category in all comers is rheumatoid factor, CCP, ESR, CRP, plus minus ANA, depending on the demographic and the clinical situation. And then if gout is on the differential, and I guess it was and still is to some degree, it would be reasonable to get a uric acid, just remembering that it's not a diagnostic test on its own.
So I can help provide some of those labs. So white blood cells were 6.9, red blood cells were 4.44, hemoglobin 14.2, hematocrit 41.4, and his CBC had a normal differential. Hopping over to his CMP, his sodium was 138, potassium 4.2, chloride 101, carbon dioxide 29, blood urea nitrogen 17, creatinine 1.04, GFR 89, glucose 93, anion gap 8.0, albumin 4.3, total protein 7.3, uric acid 7.3, and I will mention that the reference range for uric acid is 3.4 to 7, and all the labs I've mentioned up until this point were all within normal limits. Calcium 9.4, alk phos 45, total bilirubin 0.8, AST 22, and ALT 32, and the labs after that, after the uric acid, were all within normal limits as well. I can kind of walk through these now, or I can go right into our more kind of inflammatory arthritis specific labs if you'd like. Certainly. So the urgent care did obtain an ANA. So we did have on file that was negative. We obtained an HLA-B27, which was negative as well. A rheumatoid factor returned at 18 with a reference range of 0 to 15, so it was very mildly elevated. However, CCP was less than 8, which is negative for CCP antibody. High sensitivity CRP was 1.1 with a reference of 0 to 3, and the erythrocyte sedimentation rate was 13 with a reference of 0 to 15, and his Lyme antibody test was negative.
Thank you very much. So to summarize, we have an elevated uric acid, negative HLA-B27, and an elevated rheumatoid factor with 18. Otherwise, pretty unremarkable labs. But what does this mean for our case now?
Yeah, I think this is like one of those situations where the labs don't give you the answer. And I think that is really common in all of medicine. And it's really important to keep the pretest probability in mind. And so let's just go back to our pretest probability, which was maybe psoriatic arthritis. Number one, what would we expect? We would expect a negative rheumatoid factor and a negative CCP. Here you only have a mildly elevated rheumatoid factor, and it's important to remember that rheumatoid factor is only 70% specific for RA. So we have a clinical presentation that really doesn't seem that consistent with rheumatoid arthritis, and then a mildly elevated rheumatoid factor. That doesn't move RA up for me that much, and the negative CCP is very reassuring. Now, if this was a high titer CCP antibody, I think we would be thinking differently because that has a much higher positive predictive value. The uric acid is notable. I think it keeps gout on the differential, but doesn't necessarily dramatically increase the probability. It's important to remember that gout crystals the solubility of urate and is 6.8. So even if you have like uric acid levels in the sixes, which is normal. You could still have gout with levels 6 or even sometimes at 5, although the higher the level, the higher the probability. And so this keeps gout as possible, but doesn't necessarily move it up like a uric acid level of 13 might, for example. The ANA that was negative is reassuring and makes sense. There's so many consults we get for ANAs that are positive that have really no clinical meaning. And the negative HLA-B27 is also not surprising. For patients with psoriatic arthritis who have a peripheral arthritis as the main manifestations, the sensitivity of the test is like in the mid-30s. And so it's honestly more likely to be negative than it is to be positive in a situation like this. A positive HLA-B27 would have further increased suspicion for psoriatic arthritis, but a negative test certainly does not rule it out. But I think in a situation like this, imaging can be helpful to see if we can have kind of more confirmation of what's happening.
And maybe just a quick last question to the labs. We're thinking about inflammatory arthritis, but the inflammatory markers are normal here. How does that fit into the picture?
Thank you, Leah. That is a really key point. And when I was a resident, a medicine resident before I became a rheumatology fellow, I used ESR and CRP as my rule-out tests. Like if the ESR and CRP are normal, this is like not a rheumatic process. And then when I became a fellow, I realized that by using that approach, I was probably missing a third of possible cases, right? And so when you look at sensitivity of inflammatory markers, they're really good for some conditions. For example, the vasculitis category usually has high inflammatory markers. If you're working up giant cell arteritis and you have negative inflammatory markers, that is very reassuring. But if you look at the inflammatory arthritis category and the connective tissue disease category, probably a third of patients with active disease have normal inflammatory markers. And so it decreases probability, but not so much so that it dramatically changes our pretest probability here.
And I do want to remind you all that the patient had received steroids. So in our history, we also have a reason why those could have decreased as well.
That's right. That's a key point, right? And often we've kind of forget to ask or really think about what meds folks receive before they've gotten to you. And in this case, it may not only change symptoms, but as Anna points out, may change lab interpretation. Love that point.
And so as we felt in the same way when we had this patient that we would really like a little bit more information, and we thought that imaging might be able to help us out. So we started with x-rays of his bilateral feet. And he had mild degenerative changes of his bilateral great toe in the MTP joint, but no specific findings such as erosions. And he did have small non-specific focus of mineralization between the base of his third and fourth MTPs in the right hand. I apologize. I meant to say he had x-rays of both his hands and his feet. And so we're seeing that a focus of mineralization between the base of his third and fourth MCPs, in his right hand. It was said to be likely dystrophic. And given this was not too specific, we followed up with one more type of imaging. Leah, I told you about this one, and then I just received the results for the third type of imaging that we ended up doing since the patient wanted a little bit more confirmation. So the second type of imaging that we did was a dual energy CT of the right foot. which showed a single non-specific tiny focus of positive green color coating at the plantar aspect of the third MTP head on the CPPD reconstructions, which may be artifact or a tiny focus of chondrocalcinosis. Otherwise, no dual energy evidence of crystal arthropathy or of a gouty arthropathy. And then because we didn't have any luck there either, we followed up with an MRI of that left hand, specifically the left third digit, where we saw enhancing synovitis with bone edema that was consistent with an inflammatory arthritis.
Thank you, Anna. Eli, what are your thoughts here?
Well, first of all, I'm thankful for the increasing imaging modalities that we have in rheumatology, right? Because even probably 5 years ago, this would be a case where you'd get an X-ray and you'd kind of make a diagnosis based on that. But gout and CPPD and psoriatic arthritis are treated so differently, right? That it makes sense to be as sure as you can be of what the diagnosis is before you go forward. I think X-rays were kind of non-specific, and as you might expect, either in early gout or in early psoriatic arthritis, because it takes years to have erosions, which, if present, could be diagnostic because the erosions of psoriatic arthritis, rheumatoid arthritis, and gout all look different. But in this case, probably wasn't expecting X-rays to show erosions yet. Dual energy CT is like a wonderful modality that is quite sensitive for gout and may detect CPPD in some patients. It's not yet prime time for the diagnosis of CPPD. And then MRI is a great study, as is musculoskeletal ultrasound, typically done by rheumatologists, that allow you to really look into the joint. So remember earlier, I mentioned that a lot of people can have arthralgia, in other words, pain without presence of like swelling on exam. But that arthralgia is due to subclinical synovitis that we may not be able to detect with our exam, but we can detect on MRI. And that's exactly what you saw here. This MRI kind of confirmed that there was involvement in the hand that we suspected, even though there wasn't kind of swelling on exam. And so in a case like this, it was kind of not really behaving as gout, and there's no confirmatory evidence of gout. CPPD, while I think increasingly recognized as a cause of inflammatory arthritis, I think the spectrum of CPPD and of what it can do has expanded over the last decade. It still really should not cause kind of this like asymmetric arthritis like this in a 48-year-old man. Whereas psoriatic arthritis, especially with the skin findings, seems to be a much better fit. So I think to change our pretest probability, I would really want some compelling findings, right? So interpreting the imaging studies in the context of our pretest probability and always going back to that initial assessment based on the history. So I think I would be pretty comfortable with the diagnosis of psoriatic arthritis in this case.
Yeah, that's exactly what we thought as well. And we spoke about kind of different modalities of treatment. And he actually chose that he wanted to move forward with methotrexate. And so, so our goal is to treat him as psoriatic arthritis. We know that he has risk factors for gout. And so, if once we're treating his inflammatory arthritis, if he were to have another presentation more similar to gout, then we would revisit that possibility of gout in the future.
Oh, nice. Thank you so much for bringing this case, Anna. And I think To me, what stood out for this case was really this weighing of probabilities and findings throughout the case, because there was not one finding that was like a make or break the diagnosis. So it was really tricky to see with all of the findings, how do I put the different puzzles together versus just having one piece that really changes everything. And I think this case really beautifully illustrated that. And before I ask Eli for your reflection on the case too, and what you maybe want to give as three main takeaways, and I'm curious to hear your reflections and what you learned from this case.
Certainly. So, a few different things. So, the first one, which I learned in residency, is to always trust but verify in terms of past medical history, using my physical exam to verify what the patient endorses, such as the Achilles heel tenderness, the presence of types of rashes and things like that. And also, along with that, a physical exam, especially for the joints, takes a lot of practice. I really think it's one of those things where, you really need to put in hours and hours and different types of skin, different ages of skin, kind of different patients with different like backgrounds and work, and experiences to really become comfortable with that exam. And then also, we assume it's all a psoriatic arthritis, but that could change in the future. He could eventually develop gout. And so I also think this is a great case to keep in mind that in rheumatology, there's always that ability to go back to the drawing board, reevaluate from another perspective, and just keep asking yourself if what you're seeing could be the disease you're thinking of or a secondary disease, or to anticipate another disease in the future.
Yeah, thank you so much for sharing your points. Those were really key points to rheumatology and I think medicine in general. I think it's so cool how in rheumatology we use our hands so much too to examine patients. I think that is it's not as present in all specialties, and I think it's one really fun, and it's really also learning how to use your exam as a skill, which yeah, I think is really cool. Eli, what are your thoughts?
Yeah, so I mean, aside from that, Anna is a great rheumatologist. My a couple of things come to mind. I think we talked about what doesn't fit earlier in the case, and I think it's just good to kind of take that frame now that we have all of the information, our working diagnosis with psoriatic arthritis, and the things that don't fit, mildly elevated rheumatoid factor, mildly elevated uric acid, those are things that are easy to kind of explain away because of their non-specificity. So this is a case where there's nothing that's kind of hanging out there that I can't sleep with at night. And that's kind of like a good rule of thumb to make sure that you're comfortable that there's nothing that's just a really terrible fit. And there's nothing like that here, number one. Number two, I think this case was kind of made a little bit easier diagnostically because there was probable psoriasis on the skin and maybe enthesitis in the past. And that kind of really zeroes people in on psoriatic arthritis. But if those features weren't present, and let's just take out the DIP involvement too, which is kind of more consistent with psoriatic arthritis, you could still move forward with treatment in a case like this. You just wouldn't be able to label it psoriatic arthritis. You would call it an undifferentiated inflammatory arthritis. And so that just kind of speaks to the fact that once you kind of make that distinction, that it's inflammatory and that it's non-infectious, you can really help people, even in those tricky cases where you don't really know what it is yet.
Yeah, and I will add that common misconception is that the amount of psoriasis is somehow a reflection of the amount of joint involvement, but there really is no correlation between the amount of psoriatic arthritis joint involvement or the surface area of the psoriasis of skin involved with psoriasis. Sometimes I have patients that initially had psoriasis on presentation, and now 10 years later, they're like, why are you still calling me psoriatic arthritis? That was one summer. And so, it's always, I think it's good to think of our kind of diagnoses as dynamic, because they can change over time with more information or have an evolving course as well.
Thank you to the two of you so much for making this session happen today, for preparing the case, for letting us learn from it too, and also sharing your thoughts, Eli, and um, help us learn from your clinical reasoning and how you think about a rheumatology case like this. I will definitely take away this main thought, okay, what does not fit? And then with I think I'm only starting to learn this. Okay, we still treat even though we don't have certainty, but I think rheumatology is a field where you learn to live with not having certainty in many areas, but you still want to go ahead um, and help the patients um, im and be able to treat them and relieve them from their symptoms. So thank you again to both of you very much for the time also, and for everybody who listened in. And I hope to see you again soon. Have a nice rest of your day.
Thank you.
Thanks so much for having us, Leah.
Yeah, thank you. Take care.
Bye.